Good morning everybody. I am Dr. Nitin Joshi, Professor in Urology with teaching experience of 25 years working as consultant neurosurgeon. Today we will discuss thoracoabdominal incision. Indications for thoracoabdominal incision are radical nephrectomy, particularly upper pole lesion and or tumor invading inferior vena cava. Second, that is radical nephrectomy for right-sided tumor, particularly upper polar lesion. Third, locally advanced renal cell carcinoma, that is involving adjacent organs, or RCC with venous extension, or simple or radical adrenalectomy, or in case of retroperitoneal lymph node dissection, that is RPLND, or nephrectomy for benign or malignant condition, that is TCC of upper tract, or it is required in case of ileal ureter, or thoracoabdominal incision is required in case of simple nephrectomy with significant perirenal scarring and fibrosis involving peritoneum, pleura and diaphragm. Also, thoracoabdominal incision may be required in case of nephron sparing surgery like partial nephrectomy or heminephrectomy or partial polar nephrectomy in case of patient with renal cell carcinoma. The flank incision, that is 11th rib bed or 12th rib bed incision, can be converted into thoracoabdominal incision on table whenever need arises. Here, though patient is in standard typical kidney position, that is full lateral position, still if need arise, then the skin incision is extended on anterior abdominal wall towards midline or even beyond the midline on the opposite side, or it can be extended from midline downwards. Here, after incising muscles, that is external oblique, internal oblique and transversus abdominis, once one approach towards midline, one has to cut anterior rectus sheath, rectus muscle and posterior rectus sheath along the line of incision. After cutting the muscles of anterior abdominal wall, even underlying peritoneum is incised along line of incision after confirming absence of bowel loop or any viscera in fold of peritoneum. If thoracoabdominal incision is planned to begin with, then typical thoracoabdominal position can be given to begin with. After suitable anesthesia with general anesthesia with epidural, for easy and early identification of ureter in retroperitoneum, insertion of 6 French ureteric catheter can be done in the thoracotomy position. In order to drain bladder continuously and monitor urine output properly intraoperatively as well as postoperatively, per-urethral catheterization is done under strict aseptic precaution with 14 French fluids. If procedure is likely to be prolonged, then to prevent deep vein thrombosis, crepe bandages are applied when patient is in supine position to lower legs. Proper identification of rib, that is 9th, 10th, 11th or 12th rib, is done in supine position itself. 10th rib is fused with costal cartilages. One rib above the 10th rib is 9th rib. One rib below the 10th rib is 11th rib, which is floating rib, while the 12th rib can be rudimentary or absent. If thoracoabdominal incision is planned to begin with, then typical thoracoabdominal position is given, which is actually a modified supine position or semi-oblique position. Patient is brought down such that 12th rib is at the level of kidney bridge. Pelvis is rotated through 30 degree, while ipsilateral shoulder, that is shoulder on side of pathology, is rotated through 45 degree, so that side with pathology is facing upward. Lower leg, that is leg next to table, is flexed at hip and knee, while upper leg is kept straight with a pillow in between two legs. Roller is kept vertically between ipsilateral shoulder and flank, which actually gives a tilt of 45 degree. The kidney bridge is elevated to increase space between costal cartilage and iliac crest, and put skin and muscles of anterior abdominal wall on stretch. Now the position is stabilized with the help of broad sticking plaster along with Gamgee pad applied initially at the level of shoulder and greater trochanter. The Gamgee pads will protect the bony prominences. All other prominences as well as axilla is protected by Gamgee pad. The ipsilateral arm is extended over table. For better exposure, one can break the table above iliac crest as it causes hyperextension of spine. The thoracoabdominal incision can be 8th, 9th, 10th, 11th or 12th rib bed incision. The level of incision depends upon size of tumor, site of tumor, any extension in surrounding organs and relationship of tumor to surrounding structures. In case of thoracoabdominal incision, first thoracic incision, that is flank part of incision, and then the abdominal incision. Thus, there are advantages of both flank incision, that is retroperitoneal dissection to separate Girota's fascia and its content by staying extraperitoneally. Also, advantages of abdominal incision, that is release of benign or malignant adhesions to palpate liver for Mets in case of malignancy. One can easily approach and control pedicle first and prevent the tumor embolization by mobilization of the organ containing tumor. Also, one can search for additional pathology if suspected. Also, abdominal, hence transperitoneal approach will help to mobilize ascending or descending colon along white line of Told, and just posterior to reflected colon will be Girota's fascia and its contents. Thoracoabdominal incision can be extrapleural or transpleural. Also, thoracoabdominal incision may extend posteriorly from lateral aspect of sacrospinalis muscle, that is angle of rib, and extend anteriorly up to midline, or extend even on opposite side, or after reaching midline one can extend the incision from epigastrium curving along umbilicus and extending down up to symphysis pubis. Since pleura of lung comes in relation with posterior periosteum of rib on posterior aspect of incision, the incision is taken with 20 number blade from tip of rib, either 8th, 9th, 10th, 11th or 12th rib depending upon requirement. The pleura of lung descends still more down during inspiration. While taking incision with 20 number blade from tip of rib extending backward, it should grate upon the bone so as to cut all the muscles present on rib in one layer, so as to expose anterior periosteum of rib. The incision is taken along the center of rib as there is presence of neurovascular bundle along the lower border of rib. Incision is taken from tip of rib extending about 4 to 5 cm backwards or even more depending upon requirement, because it can be extended even up to angle of rib. Some cases costovertebral ligament is cut posteriorly and costal cartilage anteriorly for better exposure. The muscles present on the rib are latissimus dorsi superficially, deeper to it is serratus posterior inferior, while along the upper and lower margin of the rib are present fibers of intercostal muscle which are cut either by cautery or blunt tip scissors. The exposed anterior periosteum of the rib is cut in center, and then with periosteal elevator the incised anterior periosteum is reflected upwards to upper border of rib and downwards to lower margin of rib. At the cartilaginous tip of rib there may be presence of strong muscular attachments. After holding the tip of rib with Alice forceps, rib is separated from its all muscular attachments. Then the rib is cut with rib cutter so as to expose posterior periosteum of the rib, which forms second layer of the incision on posterior aspect of incision. If approach is extrapleural and if posterior periosteum is separated properly without perforating, then even underlying pleura gets protected. When more backward extension of incision is required, then like donor nephrectomy in renal transplant, MOP is pressed on the posterior aspect of incision to prevent injury to underlying pleura during the process of extension of incision. Thoraco-abdominal or dorsolumbar fascia is present just below the tip of 12th rib. Due to splitting of dorsolumbar fascia by artery forceps or one finger, some space is created in retroperitoneum. Then 2 fingers of the hand are inserted in retroperitoneum to develop retroperitoneal space. Then the 2 fingers of the hand are introduced properly in retroperitoneal space and parietal peritoneum lining undersurface of muscles of anterior abdominal wall are stripped off, and then the peritoneum is pushed medially. While cutting muscles of anterior abdominal wall, namely external oblique, internal oblique and transversus abdominis, they are stretched, tented upward and then cut. This is because during incision of these muscles, if the bleeding starts, then these muscles can be tented up immediately so as to control the bleeding temporarily. The neurovascular bundle is present between internal oblique and transversus abdominis muscle. While cutting the muscles, every effort should be made to preserve subcostal nerve. Once one starts approaching towards midline, anterior rectus sheath, rectus muscle and posterior rectus sheath are cut along the line of incision. Just below the muscles of anterior abdominal wall will be presence of peritoneum, which can be opened whenever required. After reaching midline, one can extend the incision on opposite side, or from midline one can extend the incision from epigastrium downwards, going up to even symphysis of the pubis depending upon requirement. If the incision is transpleural, then during this inspiration, pleura is identified, held with 2 artery forceps and incised under vision, thus preventing injury to underlying lung. Opening of pleura gives proper exposure of diaphragm. If division of diaphragm is required, then it can be done either transversely close to costal margin, which avoids damage to phrenic nerve, or vertically, which gives better exposure, but vertical incision causes damage to phrenic nerve. Whenever approach is transpleural, one requires insertion of intercostal tube drain. If the diaphragm is open, it requires proper suturing with 2-0 silk on round body. After the surgery is completed, tube drain is inserted into retroperitoneum through separate stab incision. For proper approximation of muscles, kidney bridge is lowered down. Wound is closed in layers after infiltrating local anesthetic drug in incision for giving multimodal pain relief approach. If incision is 8th, 9th, 10th rib bed, then anteriorly one may require approximation of costal cartilages with thick non-absorbable suture material like 1,0 ethylene. Thank you very much.